through contacts and networks and knowing people, it's amazing for me to present in Malaysia. So I really feel fortunate to have the opportunity. So let me just start. So because I know you guys are, I won't waste your time. So let's just get to the point. This paper was written. I hope you can see my mouse. My screen is here. You guys are here, so that's why in my face sometimes I have 3 screens. If I look here, it's because I'm looking at you. It's very nice to see you all on camera, and it kind of makes it much more lively. So I appreciate that you put on your camera. The screen is here and the camera is here. And so that's how the setup is located in my computer. This paper was written with my co-author, Marco Hefner. He is a researcher from a very well-known international research body called RAND Corporation, and he's working in RAND Europe, which is a segment of RAND Corporation. They're based in Cambridge. And with Marco, I've been working a lot with him together. So this is a joint paper that we've done. Usually I'm the general equilibrium modeler, and Marco does the econometrics, and we work together because we each specialize in our own thing. So I won't say too much about who I am because I was introduced very well here. So you can also, if what I'm doing is interesting for you, you can easily find my profile and see other papers that I've done in the topic of health economics and computable general equilibrium modeling. This specific paper, if you are interested to read and go in deeper into it, it's very easy to find. All you need to do is Google my name, Google Marco, Google RAND. You can Google RAND Europe or RAND Corporation and Google the title, and it will come up very easily. The paper has been actually very, it has a lot of, has had already a lot of impact in it. So it's very easy to find on Google if you want to read more about it. I'll start to also say to you that I've planned for this talk about 45 minutes, not too long, and just enough time also to give us, so around 45 minutes, and then we can have a discussion later. And also please feel completely free to stop me in the middle and say, I don't get it. Could you explain? I didn't understand what you said. Speak slower. If for anything, feel comfortable to unmute yourself and just talk to me, and it's going to make it much more lively. So for me, healthcare is a very interesting topic, and that's kind of actually I didn't study health economics. My PhD was on more macroeconomics, modeling, general equilibrium modeling. That was my focus, and I kind of got into healthcare by mistake because there's just been in the last 10 years let's call it a movement for health economics. There's just a lot of demand for health economists, and there's also a lot of money for funding and projects which relate to health economics. So I just kind of got pulled into it, and because I'm really interested in applied economics, I kind of go where the demands are, where people have demands for projects, and that's kind of how I go. And maybe it's not the best strategy, but it turned out a good strategy for health because I've been doing a lot of health economics because of it. And with time I discovered that health economics is healthcare is a special type of product. It's different than any other product. So it's not like so I don't know your backgrounds. I'm expecting that many of you have an economics background. Is it true, Tiru? Do people have, no, I can see that Elia doesn't have an economics background. Okay. So, okay, I don't know your complete background, but in general, when in economics, people who study economic 101, we compare we kind of get locked into a kind of a sense that there is a market, and the market and the prices of the market reveal everything. So for example, You want to buy an apple, you go and you say, oh, this is a good apple. I can recognize the quality of the apple. Apple is a metaphor for other things, for regular goods. And I go and I buy them in the market, and the price adjusts so that the supply and demand meet, and the price is a mechanism for the quality of the good and of the demand and the supply of the good. But healthcare, the cool thing about healthcare is that it's not a regular good. Actually, we as consumers, we don't actually know what product to buy from health, from a health point of view, because it requires special abilities. We need a doctor who has studied many years to actually prescribe to us the correct medicine, the correct apple in terms of healthcare. So it's not a regular good, and there are a lot of also issues. I've done a paper on the private versus public healthcare, like the debate of having more private, more public, and so on. So there are a lot of issues with private healthcare. For example, private healthcare creates something called supplier-induced demand, where the doctor tells you, you need to do these and these checks because they prescribed it to you, but maybe you don't actually need it. But if it's a private healthcare doctor, he might want to sell it to you, and you can't say no because you know the health is more important. So it's not a regular good. It's a very confusing good. Also, healthcare is not exactly a public good. Public goods are goods which are non-excludable and non-rivalrous. Non-excludable means that if the good is available, you can't exclude me from enjoying the good. So, for example, there's sunshine, like the sun. You can't block me from watching the sun. That's non-excludable. And also non-rivalrous means that the fact that you are enjoying the sun doesn't mean that it diminishes the enjoyment that I get from the sun. So healthcare is not exactly like that, because it has a lot of public good elements, but on the other hand, it is excludable and rivalrous. So it's not exactly a public good. And the final thing I want to say about why healthcare are interesting is because there are a lot of, it creates a lot of externalities, positive and negative. And we need government intervention and cross-country coordination in order to supply the good. Now, why is it? What kind of externalities am I talking about? If it was completely a privatized type of good, if you are rich, you have enough income and you can buy healthcare, that's great for you because now you're healthy. But actually, if I'm poor and I can't access healthcare and I get ill, I have COVID, I could actually infect you. So I could create a negative externality on you. So actually you have a motivation to help me in order to improve my healthcare because it won't affect you. And also, so that's one element. Another thing is in terms of positive externality, evidence, there's a lot of evidence showing that good healthcare is good for the economy because workers are more effective. We have more presenteeism, which means we work more, we provide more hours, we're more productive. There's less absenteeism, we are not so ill, we don't miss school, we don't miss work. In countries like in African countries where you have malaria, I did a project on malaria and I learned a lot about that. And so also you have like children who miss school days because they don't go to school. And so they are later in life disadvantaged. If the teacher has malaria, the teacher doesn't go to teach to school, and the students the children who go to school have a inferior education, and that affects their future life. So there's a lot of interesting stuff that is related to healthcare, and Dr. Tiro has worked on this. I know because we work together on a few projects together on the issue. So that's why healthcare is so interesting. And I'm going to explain what computable general equilibrium modeling is. So just be a bit patient, but just to say that here are some examples of the projects that I've done using this technique. So I'm going to be talking today about vaccine nationalism. but I've worked on malaria. I worked on a topic called nocturia. Nocturia is when it's gonna sound funny, but it's an issue. It's when people wake up at least every night to go to urinate. That's called nocturia. And if you wake up at least 2 times or more at night, it's called a clinical nocturia, because you wake up, you don't sleep as well, you don't have good deep sleep, and then the next day you're affected, you're not so productive. So this paper, it's now being it's under revised and resubmit in a really good journal called Health Economics. It's a top international journal, so we're very hopeful. It looks like minor revision, so I'm very excited about it. I also did a project. I did a few projects on antimicrobial resistance. This is kind of the issue where antibiotics is given too much to patients, and bacteria is becoming resistant. And we really are worried that in like 20 years, the current antibiotics that we have will be ineffective. And then we're back to the dark ages, where like a simple knee surgery or hip replacement is going to be deadly. It's going to take us a long time to recover. And it has a lot of economic costs to antimicrobial resistance. So I did a project for Canada, and I've done a project for the UK. That we were invited to do. So also very interesting projects. Recently, I'm completing a project on telemedicine in Canada. I published a paper on the importance of physical activity. And also I worked on the private versus public issue of healthcare and how it affects social value. So there's a lot of stuff which I've done already with healthcare and focusing on general equilibrium. So let's focus now. Let's go and delve directly into the topic of today. So as you all know, we have been going through this kind of crazy year in a few months already, and unfortunately already 3.3 million have died from COVID worldwide. These are the latest figures from last week. So what do we know? So during this year, 160 vaccine candidates are being developed, and already I don't know how many, but I think we have like 7, which so there are maybe 7 or 5 actually approved and used vaccines that we've received. I just got my first vaccine 3 weeks ago, called the AstraZeneca. It's the Oxford AstraZeneca vaccine. There are the ones in Europe are Pfizer, Moderna, AstraZeneca. AstraZeneca seems to have had a lot of bad publicity lately because of blood clots, and places in Europe have stopped using. But it's hard to really know what is the reason why of the blood clots. Is it has to do maybe with other underlying issues that people have? Nobody knows, but but there are different vaccines. There's the Sinovac, there's the Sputnik, the Russian, and so on. So there is light at the end of the tunnel. We seem to be on a direction of getting something. But there are still many challenges ahead, especially in terms of the global rollout of vaccine and how fast countries are going to receive the vaccines. So at the start of the pandemic, there were actually 3 possible responses to the pandemic. The first one would have been global coordination. And this is, I guess, what I would like to have seen. It's where countries work together closely to coordinate the manufacturing and the distribution of a safe and effective vaccine. It would have guaranteed a more equitable access across countries, and that's I think what we need in terms of anything to do with anything that has a public good element or an externality element. healthcare is actually almost linked, and it's very similar even to the way we think about environment. If we had a coordinated effort from countries, rather than a free riding effect of resource extraction, we would be in a better situation. So when it has to do with when there is public goods or something with a lot of externality, it's very important to have coordination, and that would have been a very nice outcome. The second option would have been an international distribution of the vaccine. So each country develops a vaccine, immunize themselves, and once they themselves are immunized, they can start being nice to others and support international rollout of the vaccine. And the third option would have been a pure vaccine nationalism, where every country to itself, we're all living in an island, we don't care. So clearly we are somewhere in the middle. We are somewhere here in the real world. So when the pandemic started, we've seen a hoarding of medical supplies and personal protective equipment. So I know now from, I've actually spoken to Tiru, and I learned that Malaysia, for example, produces 80% of the worldwide surgical masks. And in the first, I think it's 80%, you told me. And when we started with the pandemic, in the UK, there were no masks, and it was a big scramble of getting masks. It was a big deal here. And every countries were trying to, in the UK specifically, they were trying to get PPE and other medical supplies from countries. And within the US, if you were watching the news, the USA states were fighting among each other to get PPE, to get the oxygen machines, or oxygen supply machines. So there was a lot of fights for that. Furthermore, wealthier countries, they signed the bilateral agreements directly with the pharmaceuticals to secure stocks of vaccines for their own population first. And they did this without considering how this kind of supply fight affects other countries. It was even funny as a story in the US, where states bid for oxygen machines and pushing up the price. They were even bidding, governors in the US were bidding for oxygen machines on eBay, and everybody was bidding the price of the oxygen machine while it's the same country. And that was, I guess, because of the Trump era, and he was a very, a president which creates a lot of fights and competition. So even in the oxygen machine, it was just bidding up the price, and it's kind of silly because we just need to get those machines. And it was the same with the vaccines. We just need the vaccines, and it's kind of it's a funny thing to bid in such a way and push up the price, especially when countries themselves have invested, I'm saying governments have invested billions into producing these vaccines. So we're somewhere here in the middle. But we do see some kind of an ongoing international effort to support poor countries. So, for example, you've probably all heard of the COVAX program. This is led by the WHO, and it's a program to pool international resource, to combine many countries' money, pull it together so we can buy vaccines and roll them out in poorer countries. It's also it's linked with the Gavi. It's called the Global Vaccine Alliance, Gavi. I know Gavi from my work with malaria, so they also collect money to provide malaria and do research on malaria vaccines. They work together with the Bill and Melinda Gates Foundation, and so on. So there are multinational corporations to try to support countries. But the thing is that it's weak commitments, and the funding is quite scarce. So it could be much better. We could do much better, actually. Okay, so in terms of like what's going on, what has happened so far, we know that in terms of population in the world, 16% of the population come from high-income countries, but they've actually purchased more than 55% of the vaccines so far. So it's completely disproportionate to the population. And there are countries like Canada that actually bought 4 times the amount of vaccine that they need for their population. So that's kind of strange. I think the UK has done the same, and maybe 2 times over, not 4. And as it stands, 30 countries didn't even receive a single dose so far. And I don't know if you've been aware, but in like March and April, there's been a lot of problems in Europe and in other countries. And so I read recently that 90 million vaccines, which were supposed to arrive, were delayed in March and April to countries. So, and now we have a spike in India, and I'm sure you all are aware of it, and it's a tough situation for people. So there is a fight, a scramble to get the vaccine, and we've seen in Europe. There was a few weeks ago a fight, a scramble between Europe and the UK, and it's actually linked to Brexit. I'm sure you've heard of Brexit, where the UK has exited the European Union, and the vaccine nationalism element went in there as part of the Brexit debate. And so it's quite vaccine nationalism is linked to politics in some level. So it's a study by Duke University's Global Health Innovation Center. They looked at all the bilateral deals that wealthier countries made with the vaccine producers, and they looked at the limited global manufacturing capacity, and they estimate that actually, if as it stands today, low-income countries will be able to vaccinate their population by the earliest by 2024. So that's 3 years from now. That's very, very late. And so there's a moral issue, of course. But let's summarize the risks associated with vaccine nationalism, and you can see where I'm heading for, because I'm trying to motivate what we're doing in this research. So the first one is the human cost, obviously. So vulnerable population, which are mainly elderly and frontline workers, nurses and doctors. In low-income countries, they will be exposed, and obviously they're critical to the healthcare of societies. In terms of moral obligation, what happens is that less risky individuals like me, I don't have any underlying conditions. I already got a vaccine 3 weeks ago. Less risky individuals from high-income countries are treated rather than high-risk individuals in low-income countries. So there's a bit of a moral dilemma here, a moral question. And it links to, epidemiological research shows that if we would have had an equitable allocation of resources of the vaccines, we would reduce 61% of the predicted deaths compared to what we have now, which is compared to 33% of the deaths that we have from the current allocation towards wealthier nations. So we could save a lot of lives by having an equitable allocation. In terms of timing and why we want to push the vaccine as fast as possible, I'm sure you all have already heard of mutations and all this kind of stuff. So without a global coverage, we'll continue without global coverage. If we don't take care of this issue quick, mutations will just appear, because it's every day there is a mutation, and mutation is nothing special. Mutations in viruses happen regularly, and then once in a while, a mutation is more dominant, and it kind of so there's an evolutionary development of the virus. So, for example, the Oxford AstraZeneca is known to be less effective than the South African variant currently, and there are other variants, the Brazilian variants, the Indian variants, and so on, the UK variant, and the vaccine efficacy in the immunity of the vaccine is unknown with other variants. So the more we leave it and the more we don't take care of the issue globally, we are opening ourselves to the chance that the vaccine that I already have is, even if I'm in a rich country, it's not going to be effective anymore. So it's in my own interest to quickly take hold of, control the virus. And also we clearly cannot close borders, and the new mutations from other countries will come into our country and we can't stop it. So it's a risk that we need to consider. And finally, in terms of this paper, there's clearly beyond the health crisis, there's also an economic crisis. And as you know, national governments have been spending trillions to fight this impact by various policies. And if COVID continues, we'll just continue seeing travel restrictions and border closes and interruptions of the global supply chains. And that will have a prolonged negative consequence on the economy and the supply and on the demand. And that's the focus of this paper. We're not, we're looking more at the economic impacts of this, because the aim of what I'm going to show you in the end is that there is a cost benefit of the vaccine nationalism, and I'll explain it in a second. So our research, the aim of the research is to quantify the economic implications of the unequal global rollout of the COVID vaccines. And what we're doing is we basically have taken, I've already developed from my other projects a multi-country macroeconomic general equilibrium model. I've been working on it for a long time, and I took that model and adapted it so that it will work for COVID. And we calibrate the model to GTAP. I'll explain to you about what GTAP is in the next few slides. So this is just kind of like some words. So that's the aim. The aim is really to look at the economic cost of COVID nationalism. So the cool thing about what these type of models, these general equilibrium models, the cool thing about them is they can do what if experiments, scenarios. So we have like a world which we haven't seen yet, and we can do what if experiments, and we can play around. Because in real life, let's say if you want to do a policy like a tax policy or something, unless you're purely communist and you say, I'm going to, if you want to do some kind of like change of the system or some big kind of thing, you have to, if you have to be able to tell the population, I'm doing it. Let's say you want to move your population from millions of people who want to move from one region to the next. If you're an authoritarian regime that says, I'm doing it, you can do it. But if we're like in a free country where people, you can't tell me to move away, the only way for me to do it is by having what if experiments. So you simulate, you create a simulation of a country, and then you say, I'm going to move millions of people from region 1 to region 2, and you make an experiment. That's kind of what we're doing here. We're gonna, in the scenarios that we're looking in this simulation, we're gonna look at what would happen if, what would happen to the global economy and to the regional economies in terms of GDP and economic growth, if only some regions can manage to sufficiently immunize their population while others don't. That's what we're doing. Now, we will be able to say in 10 years from now, econometrics will be able to do that, but at the moment we're not there yet. So therefore, we need to simulate now. So just some overview of what is general equilibrium. So we call it CGE or AG. I have a few slides about that. So just a brief thing. Again, I don't know how much you know of economics, but I'm sure you kind of know statistics and econometrics. So first of all, let me just say I like this sentence. All models are wrong, but some are useful. Okay, so we just need to find the right we need to use the right model for the job. What is partial equilibrium models? So econometric, it's basically mainly econometric analysis, and it's very commonly used. And these type of models usually focus on the direct effects, and they have data, and they said, this is the evidence, this is what we've seen. And these are the effects that we found of one thing on another thing. In general equilibrium, the idea is that you have both direct and indirect effects. And if the indirect effects are important or sizable, then it's a useful modeling approach, okay? So that's why I like general equilibrium, because it's good for what-if analysis. So a textbook explanation is like, this is again, econometrics 101. Usually we find in econometrics, they teach us that higher education gives you higher expected income. So that's kind of a direct effect of income gives you more education gives you more income. But in general equilibrium, the idea is that if you actually flood the labor market with many higher educated workers, actually the supply rises and therefore their wage could actually fall. Now, if the negative indirect effects are stronger than the positive effects, actually it could lead to a negative income effect. And so you have and also another thing is you might have spillovers in the whole economy is linked together. And if you do something to one element of the model, it could spill over to other elements of the model, which initially had maybe no direct link. So that's why general equilibrium is really cool for what-if scenarios, which econometrics can't actually do. We use econometrics to calibrate the model, but they cannot really do what-if scenarios. So there are different names for the same thing. We call them also applied general equilibrium. These could be multi-sectoral, many sectors. They can be many households. They're economy-wide. They're non-linear. And the idea basically here is that they follow what we call Walras law, which means that supply has to equal demand and prices adjust for the market. So everything is a market. You have labor markets, you have capital markets, you have goods markets, and everything has a price adjustment so that supply equalizes demand. So the main feature of these are, they're basically, they're all functions, economical, like mathematical functions, which we calibrate, and they are all interrelated, and they are solved simultaneously. So consumers, they maximize utility, subject to the budget constraint, producers maximize profits, prices adjust, and the economic shocks from one side ripple over and affect the whole economy. So I have a nice diagram that I'm going to show you in the next slide, in a few slides from now. So they are applied because we calibrate them to real economic data. Let me close my door here. Now I promised 45 minutes, but we started a bit late, so I hope you forgive me all. And if you want to stop me for anything, please stop, because I'm talking and talking, and at some level I feel like, oh, I'm taking your time, but then I'm kind of excited to tell you about this. So please kind of, if you have any questions, don't hesitate to stop me. Yeah, so they're applied, and I'll show you how I'll give you a brief kind of intuition of how I apply them to real life data. So we use them to, so I hope that the what if concept is clear, because there is always a confusion between forecasting and what if analysis. I don't actually believe anymore with forecasts, because nobody can actually forecast the world. If I could forecast the world, the stock market, I would be a millionaire today. So that's kind of, nobody can forecast, because so what you want to do is you basically want to do what if simulation. And I'm interested always in policy. Now, I don't know how the world will turn out. When I make a model, I only look at a specific policy change, and I try to figure out how this specific policy could affect the world. But it could, and I could find that, let's say, this policy is bad. So I could say, no, this like new tax measure that you're doing is actually ineffective. It's actually bad for the economy. Let's not do it. So you never do it, and then it never happened. So that's why it's not about forecasting. It's about what if scenarios and trying to figure out which scenarios are the most, or which policies are the best, which are likely to give us the best outcome. That's kind of that's the idea of the what if scenarios. These kind of general models that I work with, they can be static, they can be dynamic, they're stochastic, so they could be whatever you need them to be. You always have to adapt the model to the job. So it's like, you use you use vehicles for something. You can use a tractor for agriculture, but then you don't want to use a tractor to commute because it takes too slow, but you need a tractor because it's stronger. So sometimes you don't want to have like a Porsche. You want sometimes to use a tractor. You don't want a sports car, you want a tractor. So it depends on what you need for the job. So sometimes if they're static, like the model that I have now, it's to compare one outcome to the next in the short run. If they're dynamic models, you're looking for like a growth horizon of projection of like 20 years from now, and you're comparing one projected outcome to another projection. In terms of dynamics, they could be recursive. Recursive just means that at each iteration, the consumers, the agents in the model are surprised by the change. And if they're intertemporal, the agents actually know in advance what the policy is going to be, and therefore today they're already changing themselves. And the real world is somewhere in the middle. We might hear about some kind of like, oh, maybe Biden, the new president, is going to do this and this, and then we're kind of adapting ourselves now, but we don't actually know what he's going to do. So the world is somewhere between recursive and intertemporal. We can add stochastic models and make it use Monte Carlo analysis. I've done it, and it gives it a bit more like we get the distribution of results, the probability of the results. So that's neat stuff. We can do a lot of things with CGE. And maybe you've heard the buzzword DSG modeling. It's kind of like the brother of CGE. DSG model is it just solves the equilibrium solution is a bit different. And then there's also something called agent-based models, which are another new type of simulations where there is actually no equilibrium, and each agent is on its own. So I won't say too much, and if anybody's interested, we can talk about this later. But they're all kind of simulation techniques. Now, in our model here, what we've done is that we have basically functions, mathematical functions for everything. And we view the world like this. So you have, on the one hand, you have producers who produce apples and bananas and healthcare and other things. And these producers sell these things in the markets. So markets are like green and agents are orange here. And you can see that here there's a double arrow because let's say you want to make orange juice, you need to go to the market and buy apples to make orange juice. So you also need intermediate inputs. Now you have here households which want goods. So they go and buy apples and healthcare and whatever. And now these households, they have their labor and capital. They have like endowments of input factors, and they go to the market and they supply the labor and capital. These guys to produce, the producers require labor and capital to build things. So they go to the factor markets, they pay wages and capital expenditures, which the households get as income. And with this income, the households can go and buy the apples and bananas. So these firms, they want to profit maximize. These guys want to have a utility maximization subject to their budget constraint. And you can see that the whole economy here is kind of in a closed loop. Of course, there's no aliens here who come in, but it's like kind of like a shell, and if something happens here, the whole economy is affected. We can add in a government, which is just another agent which consumes goods. So they need lawyers, and they need to build roads. So they need tractors, and they need healthcare, because maybe they provide public healthcare. So these guys, the government produces some kind of service, public services, but they don't have endowment of people and capital. So they need to go and collect taxes and get income from other sources so that they can buy the goods to provide the public services. And this is now a more full model. And then finally, we can also save, and not finally, it's nearly finally, we can save, and we can, so we have private savings, public savings, and so on. And finally, we can open the economy to the rest of the world, and we can trade. So we can go and we can sell some of our apples, export them to other countries, and we can import apples from other countries. And we can also ask for foreign investments and FDI and so on to improve our economy. And now in our model, we have this, and we have it multiple by many countries. So all these countries are interlinked in one big kind of big simulation. Okay. So imagine this is kind of like a very complex model with a lot of functions. Now, I'm not explaining like in detail. You will have to have a whole module, a whole lesson on this, like a whole term to learn this. I've been doing this for 20 years now, learning this stuff. But to calibrate the model, we need the data set. So specifically for this data set, for this project, I'm using something called GTAP, where it collects, it's a database of social accounting matrices. It's a multi-country database, and it's run by this center in Purdue Universities, and they cover 140 countries with 57 commodities, with all the bilateral patterns. So it really saves me the effort to, I don't have to do it for each country. If I was focusing on one country, I could use theirs, or I could make my own social accounting matrix. So what is a social accounting matrix? It looks something like this. It's a double entry accounting mechanism that we use now in the world. Everybody uses this, even in finance and any place. So you have here different accounts here within. It looks like, so here every square actually could be many accounts. So I'll give you an example of Ghana in the next slide. So you have here, let's say, various households, and households have income. Income comes from owning labor and capital. Income comes from transfers from other households, rich households transfer funds to the poor households. Maybe firms transfer funds to these households, and maybe they get remittances from abroad, transfers from abroad. So these are all
Excuse me, Dr. Erez, we can't hear you.
Yeah, hold on for a while. There are some technical glitches. Yeah, just wait for a while. Yeah, because he's speaking from England. Yeah, so probably that's the reason. Yeah.
Share screen. Sorry, guys. Share. I'm trying to share with you. Screen 3. Share. Okay. Can you see the screen?
Yes, but you have to go into slideshow. Go to slide.
Yeah.
Yeah. Okay. Fine. Good. Good, Erez. Yes.
Is it moving?
Yes. Yes.
Okay.
Yeah.
Sorry, guys. I got suddenly like, oh my God, this is a bad situation. But okay, we're back in business. Now let me open all of you so I can see you. So yeah, and I'll close the door again. So you can see that there are a bunch of numbers and there are a lot of there's a lot of information. Actually, the nice thing about SAMs is that sometimes we have less information than from compared to econometrics. In econometrics, you even need much more. So this we get so this is kind of this is a representation of this is a macroeconomy data and the macro level of the economy, and you can see here that so this is an example of Ghana. Total sum of rows equals the total sum of the columns, and each number here represents something. Obviously, for example, here these are consumers. So I've let's look at let's say consumers. Here we have consumers. I have 2 households, and they require these type of industries: agriculture, industry, and services. This is their expenditures. You have here people from the main city, Accra, and the non-Accra region, and so on. Let's say these are producers. You have here firms, a different type of agriculture firms, an industry firm, a services firm. They need intermediate inputs. So for example, the industry firm needs apples from the agricultural firms to produce apple juice, like I said. So these are intermediate inputs. This is an input-output table. These are various labor types: self-employed, skills, unskilled, capital, land. You have all the information that we need to create. So this is how we kind of calibrate our. This is how we calibrate our numerical model, which it's a bunch of functions. Cobb-Douglas functions, constant elasticity of substitution function. It's functions and mathematical functions, which we calibrate with data. And so I don't want to say too much about this because it's just to give you a bit of a sense of what's happening here. So in the specific model, we took the data from GTAP, and obviously they have 140 countries. And we combine them into 9 regions that we care about for the focus of the paper, because looking at having too many trees, you don't see the forest. So we assemble them into 9 regions. So the regions are the USA, UK, EU 27, China, Russia, India, what we call high income countries, middle income, and low income. Now, Malaysia specifically, we place them in the high income group. The reason, so we basically followed the way that the World Bank describes income classification, but at the time when we did the project, what we were caring about is on the probability that countries receive vaccines, and we put Malaysia in the high probability group of receiving a vaccine. And I think we were right, because I think that you have access to vaccines today, right, Tiru? Yeah, I can see everybody nodding. So we were right. I think you have the Sinovac vaccine, the AstraZeneca vaccine. So people are starting to get vaccinated in Malaysia. So this is kind of our approach. When we started this, this project started way before vaccines came out. We were already expecting that there would be something called vaccine nationalism, and we were right. And that's why this paper became very popular, because we kind of hit it was kind of luck that we were thinking, what are we going to do about COVID and this and that? And we were thinking, let's do something about vaccine nationalism, because in 8 months from now, when we'll finish the project, the vaccines will be already authorized, and then there will be a big fight for the vaccine. Let's see what happens. And that way, this paper became very popular. In terms of commodities, there are in the GTIP dataset, there are 57 different sectors. Again, we don't want to have too many sectors. It's not important for us. So we basically combine them into the main 8 ones, which we cared about in terms of our simulation, which directly linked to COVID. So these are the sectors that we care about, that we combined. And I'll talk about that more, because this is how COVID is going to be affected here. So this slide actually is going to explain what COVID is doing in our simulation. So we focused on the highly contact intensive service sectors, those which are most likely to be negatively affected by COVID. So for example, in the education, we were lucky, we were not affected much because we have this kind of internet ability to continue on. But sectors with close physical interactions will be disproportionately affected. Some cafes and pubs cannot be, you have to shut them down, because the only way to create the service is by actually physically meeting each other. So so without any widespread vaccine rollout, these kind of physical, will have to have physical distancing and regulation, and consumers will have to change their behavior due to the fear of contracting the virus. So these sectors will be much more affected than other sectors. And that's why so that's our focus. We looked at the sectors which have, which are much more susceptible and much more sensitive to shutdowns and physical activities, the physical distancing regulation, and these are the sectors which we affected in the simulation. So specifically, we focused on these sectors. We looked at the hospitality, recreation, and entertainment sector. So these are restaurant, bars, museums. They're important because it's important, obviously, domestically. Sorry for my phone here. It's 10 o'clock, I guess, here in the morning. So these are sectors which are important domestically, and the big sectors, obviously, and also they're important for tourism and travel. If they're closed, we lose from tourism and travel. So it also has an international link. We looked at the retail and wholesales. So these are shops and wholesale distributions, and we excluded the online shopping because obviously Amazon and Alibaba did very well during this period. We looked at the transportation. Obviously, this is very public and private transportation services. These are really important because they're actually intermediate inputs into both domestic and international production. And finally, we looked a bit at, it's not a big size of the model here, but we looked at health and social care because there is evidence showing that because of the pandemic, actually people who they avoided seeking healthcare because they were afraid of getting the virus. And actually, it might have exacerbated the severe healthcare, like heart disease and cancer, because they were afraid, they did not get the treatment. So it could have they could have created other costs of life and changes in the model. So specifically, what we did was we looked at several sources. So how do we actually affect COVID in these sectors? We looked specifically at Sweden as the main benchmark example, because Sweden was a very interesting case. They actually didn't have any lockdowns. They decided early on not to have a lockdown. They didn't have any strict containment or closure policies, and they said they wanted to go through the herd immunity approach. However, even though they didn't have any lockdown, we are able to, there's data showing that we could measure in terms of econometric, we used econometric analysis here to calibrate the effect that the consumers and the production changed due to just having COVID, because people changed their behavior because of the fact that they were afraid to get vaccine, they were afraid to get the virus. And so we wanted to tease out the changes in consumer behavior and production, and the change in production due to the fact of just having the idea of COVID. Now, obviously, each country is different, so we can't say Malaysia is the same as Sweden. So what we did was we then used Google mobility data, which is available as a proxy to talk about how based on the Swedish benchmark, these other countries would behave. So mobility data, Google mobility data, we believe we find that it's correlated with economic activities, and we linked that with this. We looked at each region and country, and we used that to adjust as an adjustment factor for the Swedish data that we used. And then we introduced this into the scenarios. So what do we do? What is this? What is our scenarios in the model? So what we're saying is that in the baseline is like the benchmark, the start, the simulation, or the scenario that is the benchmark scenario, the baseline that we compare to. And in the baseline, we're saying that's the normal baseline scenario is every country in the world, every country manages to sufficiently immunize their population and returns to normal. Now, what is normal? Normal is that physical distancing rules and regulations can be lifted. That's the idea of normal. And in the counterfactual scenarios, which is the other scenario that we're actually testing, we're saying that countries differ in their access to the vaccine. So some countries are normal and some are not. And what we're doing is we're looking at the changes in GDP across these hypothetical scenarios. So let me explain in detail. So for example, in the first scenario, in the first counterfactual scenario, only countries, only nations that have vaccine developing abilities have access to the vaccine. So in this scenario, only the USA, only EU, only the UK, China, and India and Russia, only those countries which have access to vaccine development get the vaccine and go back to normal, okay? In the second scenario, we look at all the high-income countries, or what we call I think the term here, high income, is wrong. It's more like the high-income countries with the highest probability of getting a vaccine, including China, India, Russia, all these countries, including these and these, all 1 and 2, all of these countries get the vaccine and go back to normal. And finally, all countries get the vaccine, all high income and the middle income countries get the vaccine, but the poorest countries miss out. These countries are the countries within the Gavi alliance. That was the easiest benchmark to find out which countries are the poorest countries and probably will miss out if they don't get any support. Now, okay, so this is very clear. I hope it's very clear. That's important. Good. I can see some nods here, so thanks. And let's look at the results. So remember, what we're doing is we're looking at what we compare the various scenarios to the baseline where everybody gets the vaccine. Now, in this scenario 1, only these countries get the vaccine. Compared to a world where it would have been better if everybody gets the vaccine. So in this country, in this scenario, only these countries get the vaccine producing nations. And what we find these results. Now, let me say here that we present here only the middle range results. Obviously, the data, because we don't really have any data, it's a simulation, we also have to do sensitivity analysis. So we have a middle, this is the middle range, we have a high and a low. So if you're interested if you're interested further, go and read the paper and look at the results there. So I'm just presenting the middle range. So what we see here that worldwide, if only these countries would have received the vaccine, it will cost it will cost the world 1.2 billion in terms of a yearly loss of GDP, which is around 1.3% of your GDP. The US alone would lose 127 billion. So this is actually 1 trillion, 1.2 trillion. This is 1,000 billions. And the US would lose 127 billion, which is 0.6% of their GDP. And you can see the high income countries would lose together 648 billion, and Europe would lose 310. So this is in yearly GDP that we would lose. Now, what is the key finding? What's the point here? Okay, so the key finding here is that even if one country like the US or Malaysia or the European Union, if only they would vaccinate themselves, they still lose money, and a lot of it. Why? Because we are an interconnected world, and we buy products from other countries. If other countries and they buy from us, and we have trade, we have tourism, and through this kind of the losses, because we're losing the gains from trade, we are losing. And you can see that this is very significant amount of loss. Now, in the next scenario, we are now providing the vaccine to all these countries, the countries with the high income countries or the high probability countries of getting the vaccine. And you can see that in terms of worldwide, we lose now less. Instead of 1 trillion, we lose now 300 billion worldwide. And the US now loses 30 billion. So they still lose, but by less, but they still lose. And the high income countries lose 122. So, and in this case, the middle income countries and the low income countries, they're missing out from the vaccine. Now, finally, if we add in the third scenario where, okay, the middle and the high and the vaccine producing countries receive the vaccine, there's still a loss. So the loss falls, but so worldwide we still lose 153, where the US loses 16 billion and China loses 14 billion, and the high income countries lose 63 billion together. So still there is a loss. Now, in terms of let's put this into perspective. In perspective, the US spends every year just on economic assistance as part of their overseas aid budget. They use nearly 40 billion. So 16 billion is quite small compared to the overall budget that they spend on aid to other countries. Now, Oxfam made an analysis, and they said that providing the vaccine for free to poor countries would cost the world 25 billion. They basically estimate it's like less than $5 a dose for a double dose, and the delivery and so on. It comes out to be 25 billion. So just the US and China together, the leading countries in the moment in the world, they could cover this cost. And here's the bottom line. That's kind of the message that we wanted to create with this paper, is that if we combine the combined loss to China, the US, and the other high-income countries, if you plug it all together, it's 1.9 billion altogether. And so that means, and the cost is 25 billion. So if you do a benefit to cost ratio, it means it's a nearly 5-to-1 cost benefit. So for every $1 that these kind of countries together invest in providing the vaccine, they'll get, for every dollar, they'll get nearly $5 back on the vaccine. So it's really beneficial for them to have coordinated and actually create this kind of multilateral agreement to provide the vaccine. So that's the bottom line, and this is really all I have to say for you today. Just to say that this paper, because it came in the right time, I was lucky. It never happened to me before, where we had this paper ready just when the vaccine came out. It had a lot of impact in terms of research. It reached the Biden administration just so even just before Biden was elected. He already read the report. Ursula, I have like documentation where Ursula von der Leyen, the EU, the head of the EU, has read the report and thanked us for the report. And these other organizations read the report. So we kind of affected the debate, and that was kind of exciting. This is Marco, my co-author. He's very communicative, much more than me. I'm kind of shy, actually, but he's on BBC all the time and on many reports. So he spoke about this, our reports, and our report was cited in many regular newspapers, like common newspapers, the Wall Street Journal and BBC and so on. So it reached a lot of headlines. And so I was exciting to do a paper which is useful. And that's really it. So I think that the conclusion is this. And I really thank you for your time. I think I did stick to 45 minutes, like I went a bit above. I thank you for your patience, and if you have any questions, or please feel free.
Thank you, Erez. Thank you very much for a very excellent presentation. Especially, it's really an eye-opener to all of us about the economic impact of economic cost of vaccine nationalism. Yeah. So probably we thought that the economic cost for the global economy is not as devastating when you talk about vaccine nationalism. Yeah. But in actual fact, it is. Looking at the figure, it's almost like reaching like trillions. Yeah. The economic cost. Yeah. So it's quite huge. It's actually very huge. Yeah. The economic cost of vaccine nationalism. Probably, Erez, I will just start with one or two questions while waiting for others to come up with theirs. Yeah. So if you look at that vaccine coverage so far, in fact, we see that UK is actually leading. Yeah, number 2.
Yeah.
UK is number 2. Israel is number 1. UK is number 2, and then we have other countries such as US, and these are the main vaccine producers. Yeah, these are the main vaccine producers. They are leading in terms of vaccination. Yeah, in fact, I just saw the report which says like in the UK, 35 million people at least has received 1 dose. Yeah, so probably you can just explain a bit more in terms of being a vaccine producer. Yeah, these countries being a vaccine producer, and how this has actually helped them to contain COVID-19.
So I think the way I view this, I think the US is an outlier. It's a country which is different because the US, my approach is to view the public versus private healthcare approach. I think that countries with public healthcare, it's my intuition is that public healthcare, these countries will push towards having more vaccines than countries with more private healthcare. Though the US is a bit different. Maybe the US, because they have the capacity, and also they did pretty badly so far during Trump's presidency. They quickly wanted to improve. So they've been pushing the vaccine, and they have the capacity to develop to supply the vaccine. But I think countries like the UK has a very strong public healthcare system. The NHS, the National Health Service here, is huge. It's about 80% or more of healthcare, and it's mandated. It's everybody in the UK is entitled to healthcare, and it's part of it's automatically we pay healthcare tax, which goes into the budget of the NHS. So therefore, the country had a specific push towards getting the vaccine as much as possible. You gave the example of Israel. Israel is another country which has a mandated public healthcare system. They have to, every individual in the country pays an automatic health tax, which is earmarked to the healthcare, and it can't, the government can't siphon and take away the revenues from this tax to something else. And they just did a very clever trick in that country. What they did was they decided they were really, let's call it kind of bilateral, like I presented here in the they made a bilateral deal with Pfizer. They marketed the idea as if they're going to be the guinea pigs of the world. They will be tested, the Pfizer vaccine can be tested on them. They're also willing to pay a premium price. They said, we'll pay 20% more than the going price on the vaccines. And that's how they were able to buy all the vaccine that they needed for the country and quickly push the vaccines on them, because they actually did this type of cost-benefit analysis, and they realized that, I read some figures that country did. What they said was, we are willing to pay, they calculated the price of the vaccine, and they found out that paying a premium of 20% more on the vaccine, if it could reduce, let's say, a closure of a 2-week closure, if it would reduce 2 weeks of a closure, that would already pay for the premium that they paid over the vaccine. So they had a cold hard, they made a cold judgment, a cost-benefit analysis judgment, and they decided to do the vaccine. So I think that's why, if it's kind of like a concerted effort by the public sector, they can push it. But if it's if healthcare is very private, and you would need to pay for the vaccine and so on, you would not, in my opinion, you would not succeed in pushing vaccination so much, because first of all, and also you would not be able to support lockdowns, because if I don't get any support, if I'm a healthy person and I don't have my job, I won't have an income. So I will, even if I get a little cold, and it might be, I might have some COVID symptoms, which are a slight cold, I would go to work because I need the income. If you want me to stop working, at least you should compensate me to stay home by providing me for uninsurance benefits, not uninsurance, I'm sorry, employment benefits and so on, to protect me because you recognize as a public, as the public, that healthcare creates a negative externality. So you're asking me to stay home, at least compensate me. And you can only do that, in my opinion, if you have a strong public services. It was also interesting in the US that during, Trump, when he was as a president, it was very liberal and very small government. But the moment the vaccine came out, the pandemic came out, even he introduced a lot of public support, thus internalizing the fact that healthcare has an externality and has a cost. So he supported and pushed, even though it didn't seem like it. The Trump administration pushed towards trying to do something, and thus showing that it's important.
Yeah.
So I hope I answered your question.
Yeah, thanks.
That's my personal view.
Yeah, just one more on the vaccine nationalism in India. So what happened to India, Erez? Yeah, we saw a decline in the number of cases, to almost like 10,000 a day. And suddenly, there's a surge, reaching almost like 400,000. Is there anything has to do with the diminishing role of vaccine nationalism in the context of India or what? Huh? I don't know. Probably you'll be able to elaborate more on that. Yeah.
Yeah, I don't actually know. I don't. I think that I'm not sure what is the cause. I think the cause maybe was I, I I don't actually. I think it was more about um, holidays that they had a month ago, where they
Yeah.
congregated a lot, and
Yeah. They had
I-
two very big events. One is called one religious festival celebration, and followed by election. And this actually triggered. But then the issue that I'm trying to raise is that India, being one of the major producer of vaccine, why they have not really gone, as much as we are talking about vaccine nationalism, why they were not really like able to probably roll out a, even a faster vaccine what inoculation program. Yeah, being one of the major producer of vaccine globally. Yeah, in fact they were supplying to all over the world, right? Yeah.
yeah,
Yeah.
it's a very good point. I don't know. Is it to do maybe with the variant? They have the Indian variant.
Yeah, that's one
Maybe
possibility. Yes.
that's another possibility that I've heard, but this is kind of at the newspaper level that I just from common knowledge. It seems like maybe the amount of infected is much higher than what was actually reported. So I'm not trying to say about conspiracy or anything, but I'm kind of alluding that maybe there was an underestimation of the number of infected. Maybe that has to do with the election. Maybe they're trying to make it seem like the situation was better than it was.
Yeah.
This is complete speculation, so I don't know. I just kind of my own view of.
Yeah.
It's a subjective view, so I don't have any evidence to
Yeah.
back
Yeah.
myself.
But one
Can you
point that they raise is that Indian became very, very complacent, and that actually triggered the whole thing, the second wave. Yeah, they became very complacent when the whole thing were going down like 12,000 a day. They came to a point of complacency. That's why I saw from a report that emerged from BBC, yeah, BBC News and things like that. Okay, what
Yeah.
I'll do, I'm going to open
So, but
now to our
it is,
yes, Erez, yeah.
just wanted to say it is quite amazing because the thing is the epidemic it expands exponentially. So every let's say week it doubles. So very quickly, if you don't do anything, and if it's such a big country, the moment you have 100,000, the next week it will be 200,000. Then you have 400,000, then 800,000, and so on. It's just and then 1 million suddenly.
Yeah, yeah.
So if you don't step on it quickly, it grows exponentially.
Yeah. In fact, what we did is in Malaysia, I think probably last week we had this AstraZeneca were actually offered. 268,800 doses were taken up within 3.5 hours. Yeah.
Wow, that's amazing.
268,800 doses offered to Malaysian were taken up within 3.5 hours. Yeah. And we have already started this. Yeah. And probably generally we had the fear of blood clot and things like that. Yeah. But then it's actually, if you compare with blood clots caused by other reasons, actually much higher compared to blood clots caused by COVID-19 vaccination. Yeah. I think basically
Exactly.
medical evidences proves that. Yeah. Yeah.
So yeah. So for example, in terms of blood clots, they only 4%, only 0.4% of anybody receiving the AstraZeneca gets blood clots.
It is 0.0004%.
Point,
0.0004%, which is actually
so
very, very low.
it's very low, and not only that, I'm not sure they crossed it with I think. Are you sure it's 0.0? It's so low.
Yeah,
Wow, okay.
because
I have
you
to tell my
compare
wife.
with birth control pills, the
Okay.
chances of getting blood clot is between 0.05 to 0.12%, which is actually much higher. And then for a smoker, it's actually 0.18%, which is actually much higher. Yeah.
Exactly.
So
Okay.
it's actually unfounded, I would say. Yeah. Okay. The blood clot
And I
issue.
wonder, and for healthy, if we're a healthy individual, probably it's much smaller than that number that you gave.
Yeah.
So
Yeah.
that number is the overall number in total, and
Yeah.
it doesn't actually take into account that those people who actually most likely had blood clots have other issues.
Yes, correct. Yeah, Erez, I'm just going to open to some of the participants to ask question. I'm going to call Shafiq. Yeah, Shafiq is from right? From the Southeast Asian Studies, right? Shafiq.
Yes, doctor.
First? Yeah, go ahead.
Okay, can you hear me clearly?
Yes, can Shafiq.
Okay.
Go ahead.
My question is with regard to China in vaccine nationalism in China, because there are claims saying that even some high-income countries like US and UK has the vaccines and the economy might recover soon. But somehow the economic activity will also be deteriorated because of the low foreign demand from other countries. But China, with that being said, China is on the other hand doing very well in the economy. They're pushing everything back to the right in aggregate demand and very immune to negative demand shock and negative supply shock. I'm wondering whether China can survive the economic impact for the long run. That's my question.
Yeah, thanks, Shafiq.
All right.
Thanks. Is that okay,
Yeah,
Erez, to answer?
It's a very good question. Very good. What I like, it's really nice for me to talk to you guys because you provide me with a different perspective than talking to Europeans, because obviously you're in another part of the world. So it's just really nice to have your perspective. I think that China seems to be in the same boat as other countries. So I think that kind of it's the same idea of what I was thinking here in terms of we still believe that China will be affected because they export, they import, so they are affected globally. But in terms of resilience, like you said, I think in the last 10, 15 years, China has started developing their demand from internal domestic demand. And they're much less affected globally compared to what they were 20 years ago, when they were really exporting a lot. Now, in today's world, they're much more focused on domestic demand, and they're much more resilient compared to how they were. And the data that we have, it's calibrated to the world of 2014. That's the data set that we use. So we're quite recent in terms of the data. And it takes into account their sensitivity to the rest of the world. So we're quite confident in like these kind of numbers that we show here. But I think that if we would have had COVID 20 years ago, then the effect in China would be much larger than it is today. So it's kind of like what you're saying.
Yeah, thanks. Okay. Let me go to the second participant. I think it's from Mahi, right? Mahi, you want to ask?
Yes, Doctor. Thank you. I am from the International and Strategic Studies Department at UM. And basically, you mentioned that Canada has bought vaccines in an amount that they can vaccinate their country like 4 times over. And of course, Canada is not the only country that has done this, but it has created some kind of a scarcity for the global south. So my question is, do you think COVAX has failed in regulating the distribution of vaccines between the developed and developing world? And if so, why do you think so? Thank you.
Yeah, it's a fantastic question. Yeah, I'm a bit negative, I guess. It's also a question that you can ask about, the same question about the environment. The Paris Climate Treaty these kind of questions that we just don't coordinate very well. Clearly, from an economist, usually view individuals as individuals are irrational. We want too much. We want to consume more than we can chew. You know, recently I was looking at, as an example, I was looking at on a program on restaurants where you can have all you can eat, and people just put a lot of food because it's for free, and then they throw it out, and you waste it. So at the individual level, we are not rational, and we want too many things. And in order to, the way I view it is, we need to have coordination between. We need regulation. I'm not saying that we want to have a police state and a complete authoritarian regime, but we need to create mechanism to create coordination among people. Because we always will take more resources than we need. And it's the same story with the environment, and it's the same story with the vaccines. If we can buy vaccines, we'll just do it. And so at some level, we have failed. I think COVID failed. COVAX is not strong. It has to do with really high level politicians and members of leaders in the countries. It's easy for me to say. I'm just an academic. I can always criticize. I'm sure it's very difficult to really achieve coordination, but somehow we haven't really. I don't think we've done the best job in the world yet to coordinate among countries in many different levels. So I'm a bit negative about that. But there is much more awareness today than there used to be, I think, maybe because we are now communicating through this kind of interesting platform, and I'm getting to know you, and you're many kilometers away from here. So people are starting to, the world is maybe getting closer. And so maybe there is some hope, but I think we could do much more. I think for me, I think COVID is a global crisis. It's a global pandemic, which we kind of feel it today, and we can immediately work together. Or we're trying to work together to do something, but the environment is an issue which, for me, it's kind of an unseen menace. We don't even know how the environment is going to look because we don't feel it in today's world. And it might happen in 15, 20 years, and that might be even too late already. Sorry, I'm being a doomsday person.
Yeah.
So, and we have other issues which we need to consider, like antimicrobial resistance. That's kind of another shadow. It won't be a pandemic, but it will be like, if we don't find the antibiotics soon, which can deal with changes in bacteria, then we'll also be in dire straits. So we should do more. And I guess as people, kind of at the individual level, we should be aware, and we should be pushing governments to work together and to have a better coordination. I think it's a great question.
I think one point that Erez mentioned was just now was on hoarding. Yeah, hoarding. You buy more than you're required. Say your population is like 30 million. Dual dose is 60 million, but then you buy, let's say, 100 million. That 40,000 is actually hoarding. Yeah, Erez, you mentioned that in your presentation a while ago. But talking about the global south, I think the problem had been, I think, these 2 points. The first is they don't produce vaccine. Yeah, most of the countries, they don't produce vaccine, and then they don't have the ability to purchase. So you have double disadvantage compared to developed countries, where at least they don't produce, they have the ability to purchase. Yeah, that cause actually them to hoard. Yeah, so that's the thing. Yeah, probably I'll go to the third participant, Safwan. I think you have a question to ask, right, Safwan?
Hi, Dr.
Yeah.
Thank you, Dr. Thiru.
Hi, Safwan.
My name is Safwan from the English department. You had mentioned before that the virus mutation is common in any viruses. So the mutation like the ones we see in UK, in India with the new B.16 something mutation is kind of predictable, right? So to fight this new variant of viruses, we need a new vaccine or we need to tweak the original vaccine that we have. So if this kind of situation is predictable, why does the first world country like the US, the UK, or Canada still holds vaccine? Why does vaccine nationalism still exists?
Yeah, it's another great question. It fits the same question as Mahi asked. We hoard because I think politics and democracy is not the most. It's like the best of the worst. It's the best of a system that we have, but it's not a perfect system. Politics is about politics is about getting people believing in something, showing that you're making an effort. So politicians, I think they need to consider their constituents, and it's very difficult for politicians to really be above this, and they have a political survival that they're thinking about. They have a short-term approach. It's easy again for me to criticize them, but I think that's where it comes from. So democracy is kind of it's quite limited. We're not working we're not coordinated. It's about lack of coordination, and that's where I think it comes from. And there's just fights among countries. In Europe here, we're very worried about China, for example. The European countries are viewing China as kind of a competitor for world leadership, and so there is a lack of coordination. Instead of like working together, people are trying to hoard and take care of their own. So they kind of carve the world into pieces. So China is carving themselves, the Europeans carve for themselves, the Americans are carving for themselves. And I think that also we're still really thinking, we're still we're only thinking of, we think we're the center of the world. So recently I was presenting this exact presentation in China, in a university there. And it was very interesting for me because the Chinese academic was telling me that, yeah, in China, they think that we think that, he was saying in his own words, I'm paraphrasing, we think we're the center of the world. And Europe, it's exactly the same. We think we're the center and we don't really know anything about China. So we don't coordinate, we don't work together. That's what I think is going on. And that's why we hoard.
Okay.
So we need to, somehow we need to create a facility, a better facility in the world to share the public good. There are also problems in terms of, so in economics, let me be a bit more technical. Maybe it could be interesting for you guys to listen. It's something I teach also in a course called Advanced Economic Theory. So part of the issue about so there is a concept called the Coase theorem by an economist called Coase, and he said that if we had property rights, we would be able to negotiate. And if we had markets, we would be able to negotiate and exchange properly. But the problem is that many things there are no markets for them. There's no markets for noise pollution. There's no market, and there's no property for things like common access areas, like the air and sea. Nobody owns it, and when nobody owns anything, we want to extract more from it. So we need to find a mechanism, a world mechanism to coordinate. So, for example, in terms of the environment, it's also a very interesting point. Let's say the Brazilian Amazon, the jungles, it's owned actually by the Brazilians in this case, and then many people call it the lungs of the world now. In reality, they need the farming and they need the agricultural. So I can understand why they burn the jungle, but maybe us, the world outside the Amazons. We should pay them, and we could transfer them funding so that they won't burn and they can have fun. They can, because they're creating some good for us, a public good. It's the same with the vaccines. We don't have a mechanism now to deal with these kind of things. In terms of environment, it's a bit more advanced because there is an international market for pollution. So, for example, there are quotas of how much pollution countries can create, and then countries can pollute more by buying pollution quotas. It's not working amazingly well, but they're trying to do some kind of coordination and to create economical methods to deal with it. But in terms of healthcare here and pandemics, this is completely new and nobody's done it. And it's a bit, I don't believe it actually. It's like, how could we do a market for quotas for extra? I don't know. It's so complex.
Yeah.
I don't have the solution. Sorry.
Okay. Erez, we'll go to the next participant. There's one question from Fahmi. Yeah, Fahmi, you want to ask Fahmi?
Yes, thank you, Dr.
Yeah.
Thank you, Dr. Teo, for the introduction. So, Erez, I'd like to ask your opinion about the distribution of vaccine outside the vaccine producing countries such as United States, Europe, and China. So there is a kind of like vaccine diplomacy right now, which means that some of the the middle and low income countries, they can get like maybe discounted or be donated from these vaccine producing countries. However, there is a catch. Usually these countries, the low income countries, they can only choose one, whether they choose the American or European vaccines or they choose the Chinese vaccine. Probably they can get both, but in the most cases, they can only choose one. So what do you think of this kind of vaccine diplomacy could jeopardize the chances that the whole world can be like recovered after the COVID-19? Thank you very much.
Okay. Erez?
Yeah, it's a fantastic question. So, first of all, I find it a bit. I think it's quite bad. It's really. I think I should stop here the screen sharing.
Yeah. You can.
How do I do that? Did I stop it?
Just unshare. Unshare. Go to share screen. I think you have to unshare there. Let me see whether I can unshare.
Oh, stop sharing.
Yeah. Okay.
There we go.
Okay.
Oh, that's nice. Much nicer. And I can actually look at you properly.
Yeah.
So I think that, okay, first of all, if there is this kind of vaccine diplomacy where if they force you to say, I'll give you the vaccine only if you don't take the vaccine from anybody else.
Yes,
that's what you're saying. That's really bad. I think it's not moral to do that. I think it's just not moral. I think it's not fair. But yeah, this vaccine diplomacy kind of concept is, I've heard about it. I know that I've heard that this is happening in African countries. So I think it's really, I think it's just not moral to do. And I don't know why this happens. Yeah, I have nothing.
Okay. Yeah.
It's morally, it's not fair. It's not just. Right.
Probably the politics also play the role in this kind of vaccine diplomacy, like the kind of a projection of soft power.
Oh,
yeah.
You're muted, Fahmi. You muted yourself.
Okay, I'm sorry. I think that the vaccine diplomacy is like kind of these major countries to project their soft power to show that they are really worthy to become like a global power worthy to look at.
Exactly. Yeah. So I think it's fantastic, really good point. And I'll tell you, economists usually want to put it like in a hat and say, oh, we are not in part of politics. We are showing, and this is what I was trying to do to you here. I'm trying to show you like, I'm having evidence-based and I'm just showing you the raw numbers and, you know, this is the perfect world. But in reality, economics is a social science. And there's a lot of politics in this whole story. And really, we need to find kind of a mechanism, a world mechanism where we would operate together more effectively. So there is a kind of field in economics called mechanism design. It's very interesting, where you try to create a kind of policy where each individual behaves individually, but then still the constraints make it so that we act optimally. So just a simple example, somehow we all chose in the UK to drive on the left side of the road. In Malaysia, you do the same, right?
Yes. Yeah.
You go on the left side, while actually 67% of the world drives on the right side. So somehow we all decided to coordinate and to work on the go on the left side here in this country by rules and regulations. And that's kind of the message I keep on thinking, that we need to kind of regulate and create. We need to create a fair kind of system that still allows us to behave naturally and individually, but still act morally and effectively. So I don't have a solution, but yeah, this vaccine politics is
Erez, if I could ask you this about, since we are talking about vaccine nationalism, is there such thing as glove nationalism? Because Malaysia is actually producing controls about 60% of global glove market. Yeah, Malaysia controls global glove market, 60% of it. Is there such thing as, can you come up with the terminology called glove nationalism, as what you are talking about right now? Yeah.
Oh, that's what you were. Yeah, I got confused. I said Malaysia with the masks, and actually it was the glove.
No. It's glove.
It's glove, right? Because you have a lot of the plastic, the glove.
Rubber.
Exactly.
Yeah.
The rubber.
Yeah.
Exactly. I got confused there. Yeah. I think this is part of a story of that comes from industrial organization. A lot of it has to do with there's a field in economics called, so many of you are not economists, I can see here. There's a field in economics called industrial organization. And that's a field where it talks about the monopolies and oligopolies and competition among firms. And a lot of this is really leads, it's all about, and that's bad for the consumers. So part of a big chunk of this kind of field is focuses on how we want to limit monopoly power and market power, so that it will be more fair, we'll get more consumer surplus. And somehow there is kind of an overlap between market power in the economy and also political power. When you have too much political power, it's exactly like having a firm having too much market power, because the political power helps those which benefit your close friends and your group, and it takes away and others in the minorities, other minorities, or maybe even the majority, and the minority is controlled by the majority, maybe they are even going to lose. So the political element is the same as in economics in terms of firms and markets. So all these kind of issues, vaccines, it's linked with politics, or the gloves that Dr. Tiro was saying here is linked to industries and firms competing. So that's another part of again, if we have a global approach, we could limit the cost to the consumer. So part of it's like why we have the WHO, why we have the World Trade Organization, WTO, the World Health Organization, WHO. It's all mechanisms that are made so that we can coordinate among ourselves and reduce these kind of market powers that we have and be more fair. But it's not gone strong enough.
Erez, there are two more questions. Maybe you would, is it okay for you to take another two more questions?
Yeah, I'll try not to talk so much.
Yeah. Aina, are you here? Aina, you want to ask your question, Aina? Yes, Aina Lee, yeah, okay, go ahead.
So I'm from International and Strategic Studies Department. So my question is, some countries, they have like different implementation of like the vaccination program. So like some of them have like, some of them target like older ages, like 65 and above, and some targeted like the working groups. So like, what's your comment on this situation? Thank you.
Yeah, thanks. So you're saying some have target different types of populations.
Yeah, priority for the elderly population, and she's asking your opinion on that, right, Aina?
Yeah.
Super. It's a great question. I actually I applied for a grant, which I didn't get, but in the UK we had the same type of question, same type of issue. Who do we target? So it's kind of like a very tough question, because in the reality is there is a limited supply, and we need to find who to give the vaccine quicker to most, and who is it more effective to give the vaccine to, because it's also the same question is about how we do closure. What is the optimal closure? How do we support if we ask for closure? We create lockdowns. Then how do we support people? It's the same question. Medically, the way I would look at it is, first of all, there is an epidemiological element to it. So on the one hand, you want to give the vaccine if you know that the vaccine, if you give a vaccine to someone and then the vaccine is kind of it blocks the transmission chain, then you want to give the vaccine to key people who will therefore not transfer transmit the virus. That's one element. You want to obviously give it to the most vulnerable to them. Then there is another element that you want to take into account, which people care about, is about economics and income. So because, okay, so we want to save lives, but we also want to save livelihoods. So so we need to also consider that kind of story in it. So that when we look at all these components, we need to find kind of the most optimal way to give the vaccine to people. Now I think what we would like to do as economists is kind of try to optimize some kind of like optimal way where we would put in some kind of epidemiological element into it, plus an economic element, and we would combine these together in order to give a sense of something. The problem is that we are also subjective. Again, this is a great question, because this is a perfect question for like research question, and a lot of people are dealing with it, and so I don't have a good short answer, and I don't have a good answer to you. Also, I want to admit that economists themselves are subjective people. So one economist would maybe focus more about livelihood and the value of the work, and you know, if you're not working, then you don't support your family, and you have a lot of children, and they need to eat and so on. But then the other ones would say, well, the life itself is very important, and we don't want any if you have the elderly and people who are have underlying conditions, they're more at risk of dying, then we actually want to support them, because life is more important, and we can all live in poverty a bit. We can all tighten our belt. So personally, I kind of think that we need to actually support the elderly. So I think for us, we should all tighten our belt and give more the vaccine towards people who are more likely to actually be affected by it. That's my personal belief. But your question is like phenomenally such a complex question that many people are dealing with.
Erez, let me build on what Aina asked just now. Yeah, if you look at what's happening in what vaccine tourism. Yeah, I just want to relate to whatever that we are discussing with vaccine tourism. So actually, people in Germany, the younger generation, younger group, what they are doing, they are actually going all the way to Russia to get them inoculated. Yeah. So the reason being, the younger ones, they have to wait for a longer period of time, and they don't want to really wait. So might as well they just go and buy these travel packages and get themselves inoculated in Russia. Well, what do you think about that? Yeah,
I think it's okay. I don't have personally, I think it's a bit. I would not get the Sputnik vaccine because I think it hasn't gone through
clinical trials.
Proper clinic. I don't know. That's what they say, but I think it seems a bit dangerous. So I'm surprised to hear the Germans do that.
Yeah.
And also,
I watched this documentary in BBC.
I know in Denmark, for example, I know that because AstraZeneca has this kind of reputation of blood clots, in Denmark they've stopped giving the AstraZeneca vaccine, and they only give the Pfizer now. But they gave the option in Denmark they're giving people the option to choose to go get the AstraZeneca if they wanted to. So I don't believe in this vaccine tourism for Germany, because you could get the AstraZeneca and it's better than the Sputnik. So I'm a bit surprised at that. That's kind of what I think.
Yeah, Erez, we got one more from Sharmila. Sharmila, you want to ask your question, Sharmila?
Yes, doctor. Thank you, Dr. Cyril. Hi, Erez. Hi, everybody.
Hi.
I just want to, well, after the questions from Mahi and Safwan, it got me thinking, that, how certain countries hoard vaccines and I wanted to know, doesn't this just reduce humanity to countries that have money and disregards the people from middle and low, low countries? Because having like low income and a middle income country, a lot of them don't have the resources to actually obtain these vaccines, and kind of does reduce humanity, What do you think?
What do you think? I want to hear more of what you guys think. So I'll try to be quiet now, but maybe we can open up a discussion here among you guys, because personally I think it's not fair. I think that I think for me personally, healthcare to me needs to be a right. Like, it's not like something that it could be privatized and
equitable. Healthcare need to be equitable.
Yeah, and I think it should be a human right to get healthcare. Personally, that's kind of I just don't believe. I don't believe that healthcare is some kind of good that we could get from a market. I don't think we should think about competition and markets and all this kind of. I think that we're lately in the last 100 years, we realized that education is for children, young children. It's a human right to get education. So therefore, personally, I believe that healthcare is the same. But I would like to hear your opinion. Maybe you guys can discuss it among yourselves also. What do you guys think?
Oh, Erez, is it too much for us to say that vaccine is actually becoming a luxury good? I don't know whether you're agreeable to that.
Wow,
because obviously you see that rich countries are the one who's hoarding, and the poorer countries are not really able to even like read.
Wow, I like that. I agree with what you just said now. It is true. It's there is something to do with that.
Yeah, okay.
Sounds like a luxury good.
Excuse me?
Yeah.
Could I have an input?
Yes, who's that?
Chawazi.
Shawi
Chawazi. Yes, from Asia Pacific University, major in international relations. Yeah, I think that there's a bit of a misconception that maybe lower income countries aren't receiving vaccines because I come from Malawi and it is a third world country, and it's actually amazing how many places are open for people to have like vaccination. So I think there's a bit of a misconception that we're not receiving vaccines. We have a lot of like aid and help, and they're actually coming for free. And we're about to receive our second doses. And you have countries like Maldives that like have the highest vaccination rate right now, which are also not really third world countries, but still also developing countries. So I just feel like there's this sort of misconception that we're not receiving vaccines. I think there's more of a fear of the people receiving the vaccines because of things like conspiracies and like the blood clot thing. So especially with a lower education rate, for you to kind of sensitize those people to help them believe that they should take the vaccination is something that's hard. And so what African countries are doing is they're putting frontliners to do these vaccinations, like in front of the TV, so that people can see that if these people are willing to put their lives, they're not like lying to you. So there's been a bit of a shift, and a lot of people are getting vaccinated. A lot of people that I know are like vaccinated, old, young, So that's pretty much.
I think Erez, is it under the CAVI program, right? Malawi comes under the CAVI program, is it? The one you were mentioning? Is it CAVI?
I can check.
Yeah, I think it comes under the CAVI program, under the WHO, right?
Yes, okay. I believe most of the aid comes from
WHO, because when you're saying that it's actually free vaccination, they don't have to pay. You should come under WHO, under that the one you were mentioning. I think is it Covaxin? Is it? Was it Covaxin?
It's
global role.
COVAX.
Yeah.
And COVAX works with the Gavi Alliance.
Yeah, Gavi. Oh, Gavi, not Gavi. Yeah, Gavi.
GAVI.
Yeah. I think probably that's the mechanism that they use to most of these countries in the African continent. Yeah, under that Gavi.
So Chawe, can you maybe give us more information? It's interesting. So what kind of a healthcare system do you have over there?
I mean, it's more public. And so, for example, testing for people of lower income and just basically everyone in the country is for free, and as well as the vaccinations. And so they set up tents in different areas and have people come and get the vaccination shot. And so they move across districts, because as you know, Malawi is more of those countries that have districts less than cities. And so they reach out to those areas. And it's also gone as far as interacting with the refugees and asylum seekers that are in the camps. And you have World Health Organization, the World Food Program, you have a lot of UNHCR who are involved in actually giving these vaccinations as far as to the people of concern. So it's been phenomenal. It's been a good outcome, I'll say. And people are being more trusty because of the politicians, the doctors, and all these people doing this publicly, and a lot of plays, and they're doing a lot of things to kind of educate and sensitize the people on what it is to take the vaccine and the benefits of it. And I think because of the education rate, maybe they can't understand complicated things that, because most of the things that they were seeing were complicated, and, media propaganda, and they were hearing about blood clots. They don't know what's done by Johnson & Johnson, what's done by Russia. And so they're just not wanting to take the vaccines at all until the government took this initiative to kind of start putting plays and sort of things like this. And so there's been a very big shift, and a lot of people have been vaccinated, old, young, and of course the older people were being prioritized because most young people here aren't getting that sick. And now we have a very low rate. I think 2 cases a day are coming up. Yeah,
very
so
good.
It's been pretty helpful. Yeah.
Thanks.
So what Aina Ali was asking also just reminded me to So there are different ways of, and what you just said, Chawe. In the UK, for example, they decided to vaccinate according to, they start from the top, the oldest, I mean, going downwards. And their approach here was to give it according to age, and also to separate between the first and the second dose by 12 weeks, so 3 months. While other countries, they chose to give the second dose within 3 weeks. So nobody really knows. In the UK, the approach was to try to give the vaccine to as many people as possible quick, because the first dose gives you an efficacy of around about 50, and then the second dose gives you an efficacy of about 95. So, and if you get the efficacy of 50, at least you know that if you get ill, you probably will not have a severe reaction to the COVID, and you won't have to go to the hospital.
Yeah.
You will be ill, but it won't be a strong thing. So it's so unknown, and the way to, it's quite, people don't know how to distribute effective, like the most effective is it's kind of an open thing.
Yeah. Erez, probably this, thanks Shawe for that. Yeah, the question, I have one last question here, probably we'll wrap up after this. Yeah, this is from Suzu Fujimoto, I think it's a Japanese. Yeah. It says here, travel bubble strategy will make the gap bigger between high and middle income nations. Have many vaccines like UK and poor countries which don't have enough vaccines or producing facilities. Question mark, yeah? Travel bubble strategy will make the gap bigger between high and middle income nations with poor countries which do not have enough vaccines or vaccine producing facilities. Yeah, that's from the Japanese participant just now. Yeah, Suzu Fujimoto. Yeah, yeah.
Now, I wonder, I don't know, I'm not sure that I completely agree. I think the idea of the travel bans is just obviously because we want to limit we don't want the vaccine, the virus to escape from one area to the next and infect a new area. So that's kind of that's the main idea behind it.
Yeah.
In the UK, they're creating like a system where, because UK is a very open country, Heathrow is kind of like a hub of many, it's like a stopover between many countries. So the UK is quite worried. And so I know here that they have this kind of system, green, orange, red countries. I'm not, I don't think it's I think it's kind of, there is some legitimacy in this, in my opinion. To contain. It's part of like a lockdown. I was not against the lockdown also, and we had to continue with the lockdown. I just think we need to make sure we have a mechanism to support people in lockdowns. If a country is negatively affected by a quarantine on a country, then we could, it's just like an individual country, we could support countries globally.
Yeah.
If we had a more world, like macro view.
Shawi, just to ask this question just now, do you have many choices of vaccine, or only one type of vaccine available in Malawi?
I think currently we have two.
Okay.
Yes.
Which ones?
I know there's the one made in Russia, and there's one that was being produced in South Africa that a lot of people using from South Africa. I personally have not been vaccinated, so I haven't been really concentrating, but I know there's two, definitely the Russian one, and there was one that was being given in South Africa, because South Africa had a different mutation case, so they were using a different vaccination. So most countries, I believe Zimbabwe, Zambia, Malawi, Mozambique, used this vaccination from South Africa. But the one that's being given by the NGOs is the one with the A.
No, it's so it's the AstraZeneca, I think.
That AstraZeneca.
That's yeah. AstraZeneca is it's developed here in the UK.
Oh,
it's produced,
okay, yeah.
Yeah, so the
UK,
AstraZeneca
sorry,
is
my
in
mistake.
Oxford, and it is produced massively in India. So India has a huge facility for producing the AstraZeneca.
Yeah, yeah.
Oh,
The problem
and
is the
Malawi is
AstraZeneca
a
is it's
very good partner with Britain and the UK. So it's most of our aid does come from there. So it would make sense. Yeah, because they're the ones aiding us in most of the, because it's free.
Okay, thanks, Shawi. Yeah, Erez, you have any last thoughts you want to share before we end our session, Erez? Anything? Yeah, because you're coming to an end already. Yeah.
Yeah. So just to conclude, I think that what this whole what my research was trying to do in a very kind of without any politics is to just say that actually just donating. It's almost like if all the countries, out of 140 countries we have in the world, 110 countries would donate a bit, chip in a bit, that gives them a 1-to-5 ratio in terms of outcome. And that's kind of the message that this paper was all about.
Yeah. Okay. Thanks. Okay, let us there are two things here. We're going to thank our presenter today, Dr. Erez Yerushalmi from Birmingham City University. Can we just unmute and probably give a round of applause to Dr. Erez as an appreciation for his time. He has spent about 2 hours today in Malaysia for the first time. Yeah. Can we just put our hands together and thank Dr. Erez?
Thank you. Thank you. Thank
Okay.
you.
Dr. Thiru, sorry to interrupt, but we would like to have a photo session if that's okay.
Yes, sure. Okay, Erez, they want to take a photo. So you can actually all show your faces. Yeah, Mengsoon, you can show your face. Yeah, show your face so that we'll be able to capture your your presence here. Yeah. Okay.
Hello.
Please.
So are you guys ready? So 1, 2, 3. Okay. Yeah. And one more time. 1, 2, 3. Okay.
Done?
Yes.
Are we done?
Done.
Okay. Okay. On behalf of Faculty of Art, Department of Southeast Asian Studies, Faculty of Arts and Social Sciences, and University of Malaya, we want to just convey our appreciation to Dr. Erez for spending like almost about 2 hours with us today. Yeah, this evening. Yeah. So thank you very much, Erez. We are hoping to see more of your presence, with your latest researches, so that it just gives a completely a fresh outlook of what's happening, with our present COVID-19 pandemic situation, So thank you, Erez. Yeah. Okay. So just pass back to our organizer. Is it Helmi? Mr. Helmi, are you around, or should I pass to you, or how?
Alia will take over.
Okay, back to Alia. Alia, back to you, Alia. Yeah, I'll leave it to you. Thanks.
All right, so it's the end of this session, and it is a great honor to have Dr. Erez, and he would like to give you a big thank you. So that's the end of it, I guess.
Okay.
Yeah.
Okay,
Thank
bye.
you.
Bye, see you all. Bye-bye,
Alia.
Erez.
It's an
See you all. Bye, everyone. See you all.
Thank you very much.
Thank you, Dr. Erez.
Thanks for joining.
Thank you, Doctor.
Yeah.
Thank you, Doctor. Thank you, Doctor.
Okay. Thanks for joining.
Thank you, Doctor. Thank you, Doctor.
Take care.
Thank you, Dr. Amir.
Thanks, Tiro.
Yes, Erez. No worries.
Nice and
really enjoyed it. It was really good. Yeah, really good.
Fantastic. You have a fantastic group of really interesting people.
No, actually, this was aired via Facebook as well. I believe there are more people that joined that Facebook. Yeah.
I didn't know that you can do that.
Yes, we were doing via our faculty Facebook as well. So I believe there were more people on the other side than those who participated here. Yeah.
Wow.